Hello, hello. So happy to see some familiar faces. I'll give the meeting a chance to populate.
What happened?
And if you want to say hello in the chat and maybe where you're from or where you're calling in from, what your profession is, that would be great. And then in a minute or two, we'll get started because we got a lot to cover. So I don't want to waste any time. And I am assuming you all can hear me good. Yeah. Yes. No. Okay, good. I'm traveling for a client right now. And so I am in his office instead of mine. So, new mic, different lighting, different background. This is the story of my life. Wouldn't have it any other way. AZ, so good to see you here, my friend. Got some massage therapists, athletic trainers, physios, PTs, Pilates professionals. Love it. People from all over the world as well. Got some UK friends on. I know there's some from Canada, yep, and Australia. Oh, hello, Sarah. Some of my old friends and coworkers. I love it. This is so cool. This is like what's like so much cooler about online education versus in person is you just get to connect with so many people around the world. I love it. Go Ducks. One of my athletic trainer friends from Oregon. Love that. Nice win yesterday. All right. I love it. All right. So I shared the notes for today's call in the email you got from me, as well as in the portal on Teachable. So let me know if you have a difficult time getting it, but it should be in there for you. I'll also drop it in the chat for those of you that are here now. People who join after right now, you won't get it, but like I said, it's available in multiple places. So I'm dropping that in there. And I think we'll get going. Well, I'll wait till I see it's loaded in the chat and then I'll share my screen. Love it. All right. Well, thank you for joining me on this Sunday. I know Sundays are sort of sacred days for people for many reasons. And you spending an hour and a half with me, I do not take that lightly, and I appreciate it, and I hope it will be worth it. So, all right, let's share my screen and we'll just go ahead and get started. Oh, I always forget to minimize my people box. Okay. Now we'll get started. So here you are. You found me. This is the results cheat code. It is a 6-day course, which makes it seem like a lot, but it's just going to be about a 5-hour commitment. So you've got 2 live calls, this call and a call on Wednesday. Those are both 90 minutes each. So that's 3 hours. The rest of the 2 hours is sort of spread among the 6 days. You have an intro lecture to the intro to MovementREV methodology and philosophy, and then a sort of a little hello, as well as an intro to the results cheat code and sort of MovementREV education. Those are sort of the biggest videos that you have to watch. The rest of them are all going to be like 5-minute tutorials that you can watch every day. So it's basically set up so that you can, the whole point of this is to teach you one assessment that you can use tomorrow at work, wherever you may work, and start to implement immediately. Because the key, which we'll talk about a lot, is to practice repetitions of paying attention to what you feel and how it feels on different people. And so that is what I wanted in this course, is to make it really tangible and practical so you can go into work and have a new skill to practice. And by the end of the week, feel really proficient in it in order to get good results. So this is not a course where you're just coming to listen to the information. It's very practical. Of course, listening to the information, you're still going to get a lot out of it. But again, the emphasis is the actual practical application. So in the emails, the pre-course emails I sent you, I asked you to, one, schedule out the time on your calendar for these calls, which you're here. So that's great. You're already doing that. And then also, if you can't make the live call, to schedule out a time on your own calendar to watch the recording. So you're holding yourself accountable to do the work, because the whole thing with a free course is you have no skin in the game. And when you have no skin in the game, there's less prioritization to actually do the work sometimes. So making sure you schedule that in your week is great. The other thing is scheduling like 15 minutes a day max for you to review the material first thing in the morning or right before you start work, so you know what the task of the day is supposed to be for work. So making sure that's on your schedule, that's great. And then to help with that accountability, I am also doing prizes for you all, because again, like I said, you got no skin in the game. So I want to give you something to have skin in the game. So if you show up on the live call and stay to the end, or watch it within the first 24 hours after the call ends, you will click on a link and say you were here and tell me what you learned on the call, and you'll be entered to win raffle prize. For the calls, it's going to be $150 value. It usually is either cash, a gift card, or credit towards some of my education products. It's totally up to you, whoever wins. And then there's a bigger raffle prize at the end of the week for showing up or watching the recordings of the live calls and checking in the comments every day in the course, and submitting end of the week case studies and feedback for me. And then that is a higher value. It is going to be up to $500 depending on, again, which thing you pick. So just to let you know, that's kind of the goal. And I said that on the emails as well. So before we get started, there's also, you might have already watched it, a little bit of a hello, who I am. Chances you're here, you have a little bit of idea who I am, but you might be new to me. So I just want to do a really quick who I am and what we're doing and sort of why you found yourself here. So like I said, my name is Anna Hartman. My business is MovementREV. I'm an athletic trainer by trade. I have been doing this for over 20 years. And my entire career as an athletic trainer for the past 20 years has been in a non-traditional sense. I've always worked in more of a rehab setting, sort of like a clinical setting. And I've actually always only worked with professional athletes. So I work with professional athletes in many different ways, through teams, through performance training facilities like Exos. I used to be the director of physical therapy at Exos, was one of the founding members of that company back when it was Athletes Performance. And then I started MovementREV almost 10 years ago. March 2024 will be 10 years ago. And once I started MovementREV, I started traveling with my athletes in season and out of season to take care of them, rehab and preventative care to make sure that they are feeling good and optimizing their performance. Along the way, I started putting together what MovementREV education was. So the important, and that's sort of like the important piece too, is when you're at a company, oftentimes you're practicing under someone else's like core values and someone else's methods. And so it took me a little while after leaving Exos to figure out who Anna Hartman was as a person, as a professional, and then what MovementREV was, and how was I similar to Exos, and how was I different, and what exactly made MovementREV unique and me as a provider unique. And that too is what I challenge everyone who goes through my courses to do, is also, even though I'm teaching you my methods and my philosophies, I'm not trying to create a carbon copy of myself, right? I want you to lean into what makes you uniquely you. This is also why I love the results cheat code and the LTAP, which we'll talk about in a little bit too, because the emphasis is that the tool you use doesn't matter as much as where you start. And so this is going to allow you to lean in to what you're already really good at. And that's what I believe, because every single one of you has a unique gift to the world and to your patients. And I want you to be able to utilize that. So hopefully you'll see that and start to feel that by the end of the week too, that you can really kind of lean into what you already do. There's nothing wrong with how you treat or the tools you use. And once you see that when you use them where the body wants to start, you're going to be amazed at what kind of results you get. So like I said, you'll learn a little bit more about me in the other videos in the module. And then I'm usually a very open book. If you have any questions, email me, Instagram, DM. Those are good ways to get a hold of me. And then in the comments of the Teachable, I'll be really active in there as well. So today we're going to start with this quote. This quote is from Dr. Elvin Semrad. This quote actually is taken from the book, The Body Keeps the Score. And he's not the author of the book. He was actually quoted in that book. So this was the quote. And I just thought it was like so perfect because it's exactly what I hope that you'll get out of this week, understanding that the person in front of us is the smartest thing in the world. And we can learn a lot from them. So he says, we have only one real textbook, our patients. We should trust only what we can learn from them and our own experience and experiences. And so we're going to really sort of learn how we can actually listen to the patient's body, their tissues, not just their story. Because yes, their story matters, but if we can get out of our own way and get out of our way in terms of thinking that we must fix them or we know better than them, we are going to be able to pay attention to what those tissues are telling us. And this week, especially, we're going to use an SI joint test to allow the tissues, the whole body of the tissues, not just the SI joint itself, to speak to us. So the schedule for the week, like I said, there'll be daily little tutorials. The bulk of the information is going to be today. Today's recorded module, if you haven't watched that already. And then at the end of the week, the putting it all together module is also a little bit longer, but in between there, it's about 5 to 10, 15 minutes max worth of information every day. So each day, we have a theme. Today is obviously intro, kickoff call theme. Tomorrow is learning the tests, practicing the tests. The next day, Tuesday, day 3, is continuing to practice the test and hone in on troubleshooting and improve upon your Monday. And then on day 4, I'll actually introduce some treatment for you. Again, treatment's not going to be the huge focus here because it doesn't matter what treatment you do. Ultimately, it's getting to do it in the right spot that matters. But of course, everybody, loves to learn new treatment tools. So I'll give you some of my favorites. And then Thursday, we're going to talk about putting it all together. And then I'm going to invite you to the LTAP Level 1 course. And there's 2 of those coming up. There's an online course and an in-person course. So I'm going to give you more information about that. The whole week, you'll be sort of learning about the LTAP, which is an acronym for the Locator Test Assessment Protocol. But the end of the week, I'll really share a lot more about it and about the course itself. And then Friday, I'll be sharing some cases, and then hopefully you'll be sharing some cases from the week too with all of us. The Zoom link is the same for Wednesday as it was today. And the prizes we already talked about at the beginning. So let's get going. So more than likely, you're here because we all recognize that we have a problem, whether we realize it's a problem or not. We might not at all, actually, but there is sometimes the need to feel like we need to treat patients multiple times per week and multiple weeks at a time in order to get results. Sometimes we may feel like treatment techniques are not sticking. It might feel like you're banging your head against the wall. For example, my best example of this is like when you're releasing somebody's hip flexor, especially athletes, it's like they want it every day. They come into the clinic or the athletic training room every day and they're wanting you to, dig your thumbs in there or stretch them out. And you do the treatment on them and they improve their mobility and they feel so much better. And then the next day they come in and it's like completely reset, if not even tighter. And so that can be really frustrating for both you as a clinician and then the athlete themselves. And so I often in the past kind of felt like I was banging my head against the wall with that. And in the first setting, not the first setting, but when I was in the clinical setting at Athletes Performance Exos, I had the luxury of the athletes coming to see me 4 or 5 days a week. And so I got really great results and fairly quick results. I'd say on average, everybody was like better within 2 weeks max. And so I was pretty happy with that. But I also realized in the real world, you don't have the luxury of time because one, if you're an athletic trainer in a traditional setting, you're dealing with a ton of athletes and very limited one-on-one time. If you're a physical therapist and you're dealing with health insurance or even cash pay, you're very limited on how many days a week and how many total visits you can actually really see with someone. And same thing, depending on your setting, you might only get 15 to 30 minutes with a patient. And so you don't have the luxury of being able to treat someone day after day. So it's no surprise that sometimes we don't get the results that we think we could. And then also there's that situation, which I think maybe is even more common, that you get pretty good results and you feel like a fairly successful professional. But then there's those few patients that you can't seem to help with the strategies that you are using and that helps everybody else. And those are the patients that sort of keep you up at night, right? Thinking about their cases, keep you up at night. It bothers you. It like makes you question your worth as a healthcare provider. It makes you question, it like eats away at your self-confidence a little bit as a practitioner because you're like, why are they not getting better? Or vice versa, instead of you taking the blame for it, you might blame the patient. You might accuse them of not doing their exercises, or you start to lose trust that they're being truthful with you about if they're doing their exercises or their self-care or not participating in certain activities that you did, right? And so it builds and it creates resentment, and it like I said, it eats away at your self-confidence. And so then there is this lack of feeling like you can guarantee results for all of your clients because of those few outliers. And really what it ultimately comes down to is you feel like you're missing something, right? And so you've gone and you've taken 1 million continuing education courses. Leading up until, in my recent last few years, I averaged about 8 to 10 continuing education courses a year. If that sounds like a lot, it is. Most practitioners, I would say, like maybe do like 2 courses a year. if even that, or maybe they just do all their continuing education around reporting times. And when I look back on it, one, I love to learn. Like, learning is one of my favorite things. I actually even consider it a hobby. So that's part of the reason why. But then there also was this underlying feeling like I was missing something because I wasn't consistently getting the results with 100% of my people. And because things weren't sticking, and it felt like I was banging my head against the wall. It felt like I would have a great session with the athlete. We do great manual therapy. They do great with their exercises. Their pain would be better. We were just feeling like we're in a good path. And it's almost like at the end of the day, Will Smith and Men in Black came up with that, mind eraser flasher, and it flashed in front of them. And then the next day, it's like they forgot everything. Their body forgot everything. And they even forgot all the new movement patterns and stuff they did. So, the problem, I think, is very universal. And I know from talking to professionals and hosting this many, many times, and then also being in your position, that this is probably why you're here. And so, are you missing something? No, like I said at the beginning, you have the tools and techniques right now that can actually help your patients. What you're missing is using an assessment test to figure out where to start, because where you start treatments matters. And ultimately, we know this, like, everything is connected, right? So we want to learn how to, instead of treating in silos in terms of like we're treating like PRI only or DNS only or movement impairment syndromes, like in these biased points of view, we want to consider that the body has the wisdom within it to heal itself, regulate itself, organize itself, versus there's something wrong with it and we are the expert and need to figure out what it is based on these silos that we've learned in our education. And I'm not dropping or like talking crap about those things. Each one of those tools, those systems, has so much value in it, right? These are the treatment tools that we use and have seen work with some of our patients. But the problem is the underlying belief system is it's not showing that we're trusting the wisdom of the body. The wisdom of the body that we see it, the best example that I usually give to people is that, no one taught, well, one, everything's connected in terms of like, you don't need me to tell you the anatomy that it's all connected. We know it is because we all started as one cell. We started as one cell that got fertilized and turned into multiple cells and then into an embryo. And then, eventually becomes a baby. And then this baby comes out into the world and nobody teaches it how to suck and swallow, right? To nurse and eat. No one teaches it how to move its hands. Nobody teaches it eye exercises, right? Nobody's doing like eye circles and pencil push-ups with them. Nobody's teaching the baby how to have its limbs cross the midline and start to roll over and sit up and start doing exercises to improve its core control. Nobody teaches them to go from sitting to all fours to standing, right? To walking, to running, to jumping. Nobody really intervenes with that. That is all, that intelligence is all within the body itself. And so this approach, this new lens of view, appreciates that the body is this self-tuning, self-organizing being that is fundamentally driven by the need to survive, right? Our nervous system is wired for survival. And that we have sort of like a hierarchy within the body, right? One that we know, or maybe you're new to understanding, but our movement outfit is based on a bunch of sensory information. That is how the baby ends up moving, is it exploits its environment and its sensory environment to start moving. We're still built that way. And then also understanding that movement fundamentally is how the organism survives. And it does that in a sense of it's either fighting, flighting, right? Or freezing, right? We're either running away, we're mobilizing the whole organism, or we're not moving to protect the organism, because at the end of the day, the protection of our survival is key. That also goes to the viscera and the organs within our body. The main goal of our musculoskeletal system is to protect the organs. And so if there is a threat, if an organ is not moving, or an organ is going to be exposed to too much movement on the connective tissues around it, and it might get injured, the body, the musculoskeletal system, limits mobility in order to protect it. And so we're going to see that when we can figure out that spot, when we can figure out where the body protects and start our treatment there, we innately tap into the ability of the body to heal itself and grant us more mobility and improve our movement by improving our sensory experience. So the solution, right? So now I told you what the problem was. I shared what the solution is, figuring out where to start. And how do we figure out where to start? That's not based on a bias that is sort of bathed in a biomechanical bias, right? So those silos that I talked about previously, the thing that each one of those has in common is that it's based on this bias that the musculoskeletal system, that the biomechanics is the most important thing, and that's an output. And so we need a test, an orthopedic assessment that takes into consideration not just the biomechanics, but the visceral piece and the nervous system piece too. And so that's what the results cheat code, the assessment test we're going to use, does. So the results cheat code course is learning the first test, and I think the most important test, or at least the test that can give us the quickest information in the shortest amount of time, of the LTAP. The LTAP, like I said, is an acronym for the Locator Test Assessment Protocol. It directs us where to start treatment, and its influence, as I said, the whole body. So not just the biomechanics and the musculoskeletal system, but the nervous system and the visceral components. Now, recently, one of my someone I was teaching, when I'm involved in this new soccer group coming up, and I'm like onboarding the young professionals, athletic trainers, and she said, I feel like I'm behind because I've never even heard of the LTAP. And I was like, I laughed, and I was like, yeah, that makes sense why you've never heard of the LTAP, because I made that fucking shit up. Right. And like, I say that like funny because we've got to start somewhere, right? Like, I made it up because I'll tell you the story of the LTAP. Basically, when I started learning visceral manipulation about 12 years ago from the Barral Institute, they teach this osteopathic way of evaluating, of listening to the body. Listening meaning what you're feeling in your hand, not what you're hearing with your ears through the patient's subjective history, but listening in terms of like paying attention to what you're feeling with your hands. Because we can pick up on these lines of tension or this attraction to the tissue where the body is protecting, or where the body has adverse tensions, or like patterns that the body like hugs the lesion, right? We've seen that. A good example of that in life is when somebody has an appendix that's about to rupture. What posture do they go into? A flexed posture, a little bent over to the right? They're going into hug the area of the appendix. So that happens everywhere. We have a little bit of a protective pattern, and our hand can pick up on those tissues, because it's like if we had a knot in our shirt and I put my hand here, my hand could feel that the knot was over here, right? We can feel this through our hands, but we're not very good at trusting our hands all the time, especially if it's new to you. Even though we use our hands for assessment and treatment, we tend to be so focused on what we're supposed to feel or what normal is that we forget to even just pay attention to what we're feeling. So this general listening technique is really powerful when you can learn it and become proficient in it. But it takes years of practice in order to do that. And it at first, when you learn it, it feels very a little like esoteric or a little like woo-woo. And so I found in the classes, a lot of the physical therapists that were in the program and the occasional athletic trainer, like it was too out there for them. And so they would sort of not do it. And they'd learn all these visceral manipulation techniques and they'd get some good results with them. But it wasn't consistent, right? Because it's not the tool that matters. And so you'd have these practitioners going back to the other classes. The Visceral Institute teaches, a ton of classes. So they'd go to the other curricular classes and they'd be like, oh, I don't get good results. And the teacher would be like, well, what was your general listening? And they'd be like, and the teacher could tell, well, you're not doing general listening. And so until you figure out a way to do the general listening and figure out where the body wants to start, then it's just a bunch of techniques that doesn't mean as much because where you start matters. This was not me making this up. This is what I've learned from the Visceral Institute, and Jean-Pierre Visceral, the founder of the Visceral Institute, realized in his, in his long career that where you start matters. And so I realized that if I was going to teach other professionals what I did, which up until I started MovementREV, that's what I did at Athletes Performance Exos. We had a mentorship program and we taught professionals. We were like the go-to facility for performance training and performance physical therapy type stuff. And so I liked teaching professionals, but I'm the type of person, I only want to teach what I'm currently doing. So I knew that I had to figure out a way orthopedically that I could come to find the same spot on the body that my general listening was bringing me to, because I actually really firmly believe that everyone should be able to have a way to listen to the tissues of the body without such a steep learning curve. And so one of the things I'm really good at, besides assimilating information, is puzzles. I'm really good at puzzles and I'm really good at patterns. And so I just decided I'm going to really pay attention to how I evaluate my athletes orthopedically, in addition to the general listening from the osteopathic world. And I'm going to see if I pick up on any patterns. And that's what happened, is I picked up on some patterns within the SI joint specifically, that I was started to get curious about, and then taking more of the Visceral work, and then also learning from one of my mentors, Veronica Campbell. She's a physical therapist in Arizona who is a Visceral teacher and a visceral manipulation and neuromanipulation practitioner. I learned some tests called inhibition tests from her, and I realized, interesting, if you put these orthopedic tests together, it comes to the same spot as my general listening. And so then what did I do? I tested it. I taught other professionals and I was like, how is this? Are you going to get the same results that I do? And they started getting really good results too. And so when I started my mentorship in 2018, I remember telling them, I was like, I tried to teach people everything I knew, everything I learned for 20 years. I tried to give them in 4 months, which is a lot of information. And I found myself saying, if the only thing you learn from this mentorship is these 5 tests that figure out where to start treatment, that I know you're going to get really great results and get everything you paid for this mentorship. And like I said, sure enough, they started doing that. And I didn't have a better name for them other than I was like, I know these help you locate where to start. And so that's why I called them the locator test assessment protocol. And that is what I teach now. And now I've taught hundreds of people through the program. And now I have even better results that it works. So that's my story of, if you've never heard about the LTAP, I mean, you're right. I made it up. But that's sort of where the FMS was about 25, 30 years ago, right? So the only way to push the profession forward is to introduce a theory or a model. That is science. The scientific model is to introduce something like this and have people test it out and refute it or agree with it. So that's what we're doing here. So back to this week, we're going to learn the first test. Like I said, I think it's the most important, but really it's just because it saves us time. I like to refer to this test as a traffic cop. If you look at the map on the right, it's like a transit map, right? Like a subway map. This is sort of what I think of when I do an orthopedic assessment on someone and I end up with a laundry list of objective or even subjective problems that I need to address, right? Like I might evaluate somebody and be like, oh, shoot, you're lacking hip internal rotation on the right and ankle dorsiflexion on the left, and you don't get full scapular upward rotation on the left, and you're limited in thoracic mobility going to the right, and in your movement patterns are like you have this energy link or this movement impairment syndrome or whatever, right? I think we all are good at figuring out that list. But then we're like, where do you start? Right now, you start based on the silo that you resonate with the most, right? Like if you're PRI, you probably start with breathing. If you're DNS, you probably start with breathing. If you're a pelvic floor physical therapist, probably start with the pelvic floor. If you're a Gary Gray type person, you probably start with the feet. If you're a Gray Cook disciple, you probably start with the thoracic spine or shoulder, right? So the first test of the LTAP, this SI joint locator test, is a traffic cop to take all of this information, use this one test on everyone, not just people with SI pain. This is going to be for everyone, whether they come in with a knee problem, an ankle problem, or a neck problem, right? This traffic cop is going to be like, treat the viscera or the central nervous system first, treat the lower extremity on this side first, or do whatever you want, right? So this test is going to quickly give us 3 options. And then once we have those 3 options and we start there, we can use whatever tool we want, and then we're going to reassess everything. And what you'll find is all of a sudden it becomes clear that what line you want to take on that transit map. It's like, oh, what really matters is their hip internal rotation on the left. So I'm going to go there now. Right. So this is sort of the thought process of what this test is for us. It's a traffic cop. The core beliefs of this and why it works is because the SI joint connects everything. It connects everything. And its mobility is influenced by those connections. The other belief, which we've already been talking about, is where you start matters more than the tool or technique you use. So today we're going to talk a little bit about the anatomy around the SI joint so I can prove to you this core belief, at least begin to prove to you this core belief. But really, it's the practical work you're going to do this week that's going to prove to you that these core beliefs are true. Don't take my word for it. This is what I tell my athletes too. Don't take my word for it. I want you to feel it in your body, in your hands. I want you to see it with your patients, right? So this is sort of what we're working around though. So in fact, Jean-Pierre Barral, he refers to the SI joint as a visceral joint, meaning that it's very influenced by the viscera. So you can't assume if it's not moving that it's a structural problem with the SI joint itself. So I'm going to show you those connections, and then you're going to see it in real practice during this week that him and I both agree. The cool thing is, remember I said that I started paying attention to some patterns I saw in my athletes when I decided I needed some orthopedic tests to confirm my general listening. The cool thing is I hadn't heard that Jean-Pierre said that about the SI joint. It wasn't until COVID, like 2020, so 3 years ago, that I realized that Jean-Pierre and some of his colleagues in Europe also use the SI joint as a witness in a similar way. And so I was like, well, glad I'm in good company of the patterns I noticed, right? So now I'm like, it was confirming to me, because not only have all the people I taught seen these results too, but I'm like, okay, they do see this. It's just not the way they teach it in the courses. So we already talked about what the acronym stands for: Locator Test Assessment Protocol. It's a sequence of orthopedic-based tests to listen to the body to determine where to start treatment and the sequence of treatment. this is a little review from what's already in the teachable, but to give you an idea sort of how this fits in the whole MovementREV method and education. This piece, this assessment piece, is sort of like the fundamental level that I love people to start with, is learning the LTAP, or at least learning this test, the first test of which we'll learn in the results cheat code, because like I said, if that's the only thing you ever do, you're going to get great results with it. And then if you want to learn more, you can, one, learn the rest of the LTAP, which we'll talk about more at the end of the week. But then two, in the mentorship, like we see more like big picture and learn a ton of tools and exercises and movements and theories behind stuff too. So it's sort of like my Ascension models of how you learn the entire MovementREV system and methodology. So the other tests, just so you know what they are, the SI joint mobility test is what we'll be focusing on this week. That's the first one. That's the traffic cop. And then depending on where the traffic cop tells us, we're going to go to look at the central nervous system on its own, the thoracic container, and then use visceral inhibition tests for the abdominal and the pelvic containers, and then also neurovascular inhibition tests using the pulse as a guide for that. So those are the 5 tests. So the first test gives us a ton of information, almost, so depending on your tool that you use, you almost sometimes don't even need the rest of them. And then test number 2, 3, and 4 give us more information about what viscera it is. And then the 5th test is going to be the direction we would go. Actually, we'll find that out with the SI joint. It's one of the traffic cop directions. So these are the questions that are answered with the LTAP, and then specifically the ones for the results cheat code. So you're basically asking the body where to start. You're asking, can I treat anywhere I want, right? Or are you protecting something important like the central nervous system or the viscera or a peripheral neurovascular thing? And then depending on the answer from the results cheat code, right, depending on where the traffic cop directs us, the rest of the LTAP answers the question, what exactly is it? It gets us more specific. So I always tell people, the more we can narrow it down to be more specific and precise, the better the outcome. It's sort of like throwing a rock in the water. When we throw a big boulder in the water, makes the big splash, but that's it. It sort of dies out a little bit. When it's a pebble, it's gentler, it's more specific, but it actually ripples for quite a long time, right? So that's what we're looking to do, is narrow things in with the rest of the LTAP. But right now for us, like if you've never really given thought that the body can direct us where to start, it's taking us from all these objective dysfunctions and narrowing it to here, right? And that we're going to get a much better outcome here than we were going to with here, right? You can see how all these objective functions is going to take us a while to get through. Whereas here, we're like, oh, it's more clear now. So why can this approach and treatment option be so powerful? I talked about it a little bit, but it goes back to the nervous system. It's fundamental sort of drive for survival and safety, right? So when we treat where the body is protecting, it inherently promotes feeling of safety. For example, if somebody is in that sort of side bent position because they're protecting something in their, body, whether it's like, gut problems or overloaded liver or like even like asthma, right? We can get like some lung stuff going on and we get in a little protection pattern of side bending and flexion forward. If I look at that and be like, oh, look at how limited they are, we need to stretch all that tight stuff and go this way. It's forcing the body out of the protection pattern. When you force somebody, what is the natural response? If somebody wants to be here and I'm forcing them over there, it is usually met with what? More force, right? If you push me, I'm going to push back. And so you already increase this threat mode And when you increase the threat mode, you're more likely to have that Men in Black situation of no matter if you got them out of that side bending pattern, they're going to go right back to it as soon as you turn around, right? So this approach is powerful because it identifies exactly where that protection pattern is, and we meet the body there and do treatment in that spot to be like, hey, let me help you out. I see you have a problem here. Like, let me carry, like, oh, look at all those bags you're trying to carry from your car to the house after a grocery store. Like, let me grab the bags for you. Let me help you out. And it's like, oh, that feels so much better, right? So that's part of it. When we eliminate the protection pattern, we feel safer, we're granted more mobility, our pain decreases, and we facilitate autonomic nervous system regulation through amplifying our parasympathetic response, because that is our safety side of the things. When we do that, we tap into the body's ability to heal itself, right? So now you have the amazing innate cellular intelligence on your side for if somebody has pain or a wound or whatever is going on, their body goes into healing mode, right? This is why sleep is so powerful, right? That's when all the hormones and things happen in our body that heals our tissue and decreases pain and gets things to optimize well. And so we want to leverage our treatment to facilitate this parasympathetic nervous system, this safety feeling. So if we can do one simple test to be like, oh, the problem is, over on their right hip, start there, even if it's a left wrist issue, we're going to have a better outcome than just going straight to the wrist or going straight to the scapula or with the neck or whatever it may be. So for the course, the goal for the course, we're going to practice the assessment this week. It's why we're only doing like one chunk of the LTAP. Remember, treatment is the easy piece. You're going to want to like jump ahead to treat everybody and use the new treatments. And I really can't stress, like, be patient about it. I encourage you also to be curious about proving or disproving the core beliefs to be true, right? So that just means that you have to sort of be okay with doing things differently and being a beginner again, right? Like coming to these tests, they might be tests that you already do. You're going to come to it with a new lens of view as a beginner so you can do them differently with a new lens of view of this visceral and nervous system, whole organism priority. And with that, you need to let go of the need to be right. The SI joint test, especially, one of the hardest things that people have with it is like, they're like, I don't know what I feel. I don't know what's right. And I'm like, doesn't matter. Doesn't matter. Being right doesn't matter. You got a 50% chance, pretty much. And if you're not right on this rep, maybe you'll learn from that and you'll be better on the next one. So this is what it's all about, is getting the repetitions. So you're stacking your chips in favor of getting it right. But what you'll notice is the letting go of the need to be right allows you to actually pay attention to what you are feeling. Because when your hands on somebody and you are thinking about what you should feel, that is you thinking about what is right. And you've already lost the battle because you're in your head and you're not in your hands. Okay. And then what's really important for you to see how this works is to reassess your people. So you're going to assess them like you would normally do. You're going to add this test on, see where it directs you. You'll do treatment where it directs you. And then before you do anything else, you got to reassess so you see what's changing. If you don't reassess and just take my word for it, you're never going to know if it actually, you're never going to know. If you never reassess, you're never going to see just how amazing the body is at making changes. So the reassessment piece is important. So now to the meat and potatoes. Why the SI joint? How to perform it. I'm going to talk a little bit about SI joint pain in regards to the test. On Wednesday's call, we're going to break down SI joint pain more. I know a lot of you signed up because of wanting to learn more about your patients with SI joint pain. So we will talk about it, but it's more on Wednesday. And then we're going to talk about why breath hold creates a change. Breath hold is part of the test. So we'll learn about that in a second. So why the SI joint? I already shared that Jean-Pierre calls it the visceral joint. I think it's a visceral joint. I told you that's one of the core beliefs, that it connects to everything. The other cool thing that makes it a good joint, it's a good tester joint because of its movement. So movement happens. There is movement at the SI joint. Movement's present, but it is very limited. So there's not a whole lot of room for interpretation. I love that, because then it's easier to be like, is it moving or is it not moving? I always give the example of the shoulder. Who am I to say that this is full mobility or this is full mobility? Right? Like it's like, we're not even, I don't want to say full, take the word full out of it. Who am I saying, is this a mobile shoulder or is this a mobile shoulder? Right? How do you delineate when there's so many degrees of motion available? In the SI joint, it's either going to move or it's not going to move. So your job this week too is to stay that black and white about it. It's going to move or it doesn't move. It's not, you're not going to be like, well, it doesn't move as much. If you say it's not as mobile, or you say like it moves less, then if it moves less, it's either, again, it's not moving or it's moving. So are they both moving or are they both not moving? If they're both not moving, it's okay if you don't think one side is, like, you don't have to pick a side. What you need to pick is if it's moving or not, because the breath hold part of the test, which we'll talk about, is going to give us more information. So movement is key. Movement is key to understand that, one, there is movement at the SI joint, right? It's little, but it's there. And this is what makes it a good test for this, because it doesn't leave a lot of room for interpretation. But then also movement and function of the SI joint is influenced by visceral, neural, and musculoskeletal factors. So that makes it a perfect area assess to investigate issues that have a whole body effect of the anatomy. A lot of times when I teach this to people, the question is then, what's the upper extremity version? Because they think of the SI joint as being part of the lower extremity or the trunk. But again, I'm telling you, it's connected to everything. The SI joint mobility locator test is used as a whole body assessment. It will be influenced by visceral and nervous systems. And the upper extremity, if you're new here and you weren't here for my Never Treat the Shoulder First lecture or podcast episode, you'll know that upper extremity is never where the problem is. Upper extremity is sort of like along for the ride. It's either going to be visceral, central nervous system, or a kinetic linking thing from the lower extremity. Does that mean you'll never treat the shoulder or treat the elbow or treat the wrist or get injured at those spots? Absolutely not. Of course you do, right? We know we have problems in the upper extremity. I'm just saying it's not driven from there. And if you can find the driver of the problem, you're going to help people with elbow pain or wrist pain or shoulder pain way quicker than just going to the upper extremity itself, right? So even it's just, that is just, you got to trust me on that. But then part of trusting me on that is seeing it for yourself this week when you're practicing it. But I promise you you'll be shocked. Actually, I hope you have an upper extremity thing going on this week with somebody, because I want you to see how the SI joint changes. And then also how their upper extremity issue changes with it. So another concept of this sort of traffic cop / transit map is ultimately the SI joint is a transfer station. So this is, we're going to break down like all the influences on the SI joint. At the end of the day, the SI is a transfer station from transmitting information from our legs through our trunk to our head and arms, right? So we know that it's an important part of the body in our locomotive pattern because of our rotational mechanics. right? So this is part of the reason why the SI joint has to move, is because our rotation, our gait, is created from the spine, not just the legs amplify it. So we can see this, right? This is probably this transfer station or this musculoskeletal connection across the SI joint is probably the one that's most known, right? We talk about a forced couple of the muscles, like forced closure of the SI joint, of the oblique sling systems that go across that joint, right? So we know there is this relationship between the obliques and the glute max and the hamstrings, right? This crossing at the SI joint. And we can also see it with this test. This test, you might be familiar or not, I don't know. I call it a supine ground reaction test, but it's basically like how we're seeing forces go through the SI joint as we mimic ground forces through the foot. So this test is basically mimicking what's happening when the foot's hitting the ground in weight bearing, right? I want to see, as she loads, has impact ground reaction through her foot, how it travels through her body. A normal loading pattern would be for a force to come up the leg and then cross at the SI joint and come out to the opposite head, neck, shoulder area. So I'm basically going to create that ground reaction force on her foot. So I come down here and make sure she's nice and relaxed. And I hold just gently under the heel and I press her foot into dorsiflexion. And I can kind of play around with which parts of the foot. This is nice too. If somebody's having pain or you think they're like overloading one part of their foot, you can kind of see. So when I load her on the outside of her foot, it sort of, she might even be able to feel it sort of ends and dampens here. It doesn't really cross her SI joint very well. When I load her dorsiflexion more straight on, it goes up a little higher in her body, but it's still kind of staying one-sided. So what's happening with her is I see it come up and then this whole same side feels like it's getting the jostling and then just her head's moving. I'm not seeing a lot of that crossing pattern here. So then I'll do the other side. And here is a better pattern. So it goes up her legs and then it crosses over to her opposite shoulder. Her head's still moving. That's a normal reaction. I do like to see the head moving, but I want to see a diagonal path of force versus a straight line. Now in this hip, what I notice is the force is really far lateral. Sometimes I'll see it a little bit more medial on people. That might just be the shape of her pelvis. And all right, so that's a good test to sort of see this this force transfer through the SI joint. And it's also one that it could be an SI joint mobility test on its own, because you're going to probably see how it correlates to the tests that we're actually going to use. Now, this is not one I necessarily am having you practice, but it helps to sort of visually see that transfer station scenario really well. So again, these are going back to sort of that initial picture of just, this is a concept that I'm sure you are all familiar with across the SI joint, of like how our muscular sling system helps to reinforce this closure and this relationship of energy transfer from a locomotive standpoint in the body. So what you might not consider, though I'm sure you know the anatomy, the SI joint is an important part of the central nervous system. So the central nervous system is the brain and the spinal cord and its corresponding containers, so the cranium and the spinal column, and it attaches right via the filum terminale down at the bottom of the sacrum at the coccyx. And so when we have a tension pattern in the central nervous system, this is going to affect the position of the sacrum, right? So if you have ever gotten craniosacral or you've studied craniosacral therapy, like that's what it's named for, right? Craniosacral is the actual, central nervous system connection points. And so, of course, the SI joint is influenced by our central nervous system. I mean, this means that we can have a tension up in our cranium from, and from anything really, right? Like easy scenario is like a TMJ issue, right? A lot of people have TMJ type issues. Well, that is very linked to our trigeminal nerve, which is very influences our intracranial pressures. And so if we have a tension up there, our whole central nervous system can side bend to that side and change the SI joint position and make one SI joint more hypomobile, whereas the other one is moving, or maybe it makes them both hypomobile, right? So the central nervous system is directly connected to it, just like the musculoskeletal system was directly connected to it. Then you have the visceral piece. There's sort of different layers of the visceral piece. One is the fascial containers that the viscera are in. They're connected from our cranium all the way until our pelvic floor. So those fascia, that fascia lines the front of the SI joint. It interdigitates with the SI joint ligaments and the muscles, right? And so it's like it is continuous. It is connected. Not to mention that there are many visceral organs right in front of that SI joint, and their ligaments directly attach to either the pelvic bowl walls, right, the walls of the innominate bones, or the sacrum itself. So if there is tensions around this organ, right, like if you're constantly constipated, or you, even during our periods, right, as females, when we have our menstrual cycle, throughout the ages, as well as just throughout our monthly cycle, the shape and the position of our uterus changes. And so you can see how when the uterus changes position or shape, it pulls on the sacrum. Same thing makes sense when we're carrying a baby in our uterus. It's pulling at the bones, right? It is no surprise, not just hormonally, that women while pregnant or postpartum have a lot of issues around the SI joint and around the spine itself, right? Because not to mention pelvic floor issues, right? So even though we've all learned about the viscera in school, we forgot that it actually attaches to the skeleton, right? And it acts just like ligaments and joints in the skeleton act on the body. So it's sort of just bringing us again back into this full, more whole body approach, appreciating that functional issues in the viscera and physical issues along the ligamentous attachments of the viscera can change our external or internal mobility of our organism, right? The movement outputs, and also be a culprit with pain. Then, of course, you have the peripheral nervous system piece. So what is the peripheral nervous system piece? Well, each joint is innervated by nerves from the periphery, right? And so the mobility of the joint, the SI joint, the hip joint, the knee joint, ankle joint, all of our joints, their mobility partly is dictated by the information to and from them from the nerves, right? And so it's important to understand what nerves innervate the SI joint, because that can mean that there's a bunch of other nerves or a bunch of other parts of the body that are also innervated by those nerves that can be sending information back to the spinal cord and the brain that results in not a clear message to the SI joint and changes our mobility, right? And so we look at the nerves, and there's a slide that tells you the nerves, like the breakdown of it coming up, but it's basically like the picture on the left, the green nerve there, that's the obturator nerve. The obturator nerve is one that we'll actually learn a nerve glide for this week, because it's a really powerful nerve, because one, it innervates the SI joint. Two, it also innervates the hip joint and the knee joint, the adductors and the skin on the inside of the thigh, but it also innervates the parietal peritoneum. The other nerves that innervate the SI joint are the superior gluteal nerve. So the superior gluteal nerve is right here on this backside. It's also innervated by the lumbosacral trunk right here. And then the little spinal nerves from S1 through S3 also innervate the SI joint. So there's a huge connection to the peripheral nervous system. So that was that fundamental core belief, right? That the SI joint is connected to, influenced by everything. The viscera, the central nervous system, the peripheral nervous system, and the myofascial or muscular system, musculoskeletal system. So here are those nerves right now. So the obturator nerve, which is the visceral connection, we're going to talk about that a little bit more. The lumbosacral trunk, which the lumbosacral trunk is the beginning of the sciatic nerve, which is really two nerves, the tibial nerve and the common peroneal nerve. And so hopefully that makes you think like, wow, all of those nerves, like that means that anything in the lower extremity can influence SI joint mobility. Yeah. Yes. This inherently, which we'll talk about Wednesday when we talk about SI joint pain, is part of the problem of why it's so hard to diagnose SI joint dysfunction or pain, is because that joint, since like Burrell says it's a visceral joint, which the viscera is the nervous system too, it's just, you know, it's hard to nail down when it's an actual structural problem of the SI joint ligaments itself. All right, so now how we perform this. So we're going to do two tests. You don't need two tests, but I introduced them because one you're probably familiar with and one you're not as familiar with. So I like to have a familiar one so you have sort of a built-in reference point for yourself if you're doing it right? Even though I promise you are, don't worry about it. But then also, it gives us some options for people who are not hands-on practitioners, or for those of you who see virtual clients and can't put your hands on someone. And then also for clients who can't lay on their back or don't like to be pressed on with their hands, right? So it just gives us some options, but ultimately we're looking at the same thing. So the supine SI joint mobility, this is sort of my more gold standard one, is basically just a like joint mobility test of the SI joint. You're doing an AP glide of the innominate bone on the sacrum and assessing the end feel. You're going to do that test regular and then with a breath hold. So you're going to have the person inhale and hold their breath. It's not a big inhale. It's not like you're taking the biggest breath in the world. You're just inhaling and holding it, and then you're going to reassess it. So a normal joint feel is a firm ligamentous feel. I was explaining to somebody recently, I'm like, it's like a tightly wound spring. If you were going to go to stretch it, it like gives and has a little return to it. It's not like bouncy like a trampoline, right? But there is a spring feeling to it. Hypomobile is a hard end feel. Usually, sometimes, depending on the width of the pelvis, what you'll feel also with the hard end feel is sometimes the whole pelvis will rotate in response to your load. So if the whole pelvis is rotating when you're just trying to load the one side, chances are that one side is not moving. Reminder, we're not assessing hypermobility. It's either mobile or it's not mobile. So here's the video of the test. So this is your more bird's eye view or clinician view of what's happening in this test. So we got the sacrum and the innominate bone. What we're doing is doing a posterior glide on this innominate bone to check the mobility of that SI joint. Now, this is a good way to show you how it matters where your arm is. You're going to want your line of push or pressure to be in line with the joint line. So that's going to determine on where my forearm is, right? So on this model, I'm going to have my forearm out here to match the line of the joint and compress, right? So when it's your client, you have to sort of, guess what it is a little bit, but also be able to feel it. So when I was learning this, I would just intentionally go narrow, go wide, go in between, and see what gave me the better mobility test. So hers feel, when I take up the slack of the table, feels like right there. And I'm going to do a posterior glide on the left. It glides and it's a little bouncy. It follows me back up when I let go, which is a normal joint feeling for that joint. On the right, I press down and it takes her whole pelvis with me. So it gives me a hard end feel and then everything accommodates. So this is the hypomobile side. I'm gonna have her take a deep breath and then hold it, and I'll retest. And that gives me that springy feeling. So that means that her locator test is directing me to do treatment in the viscera or nervous system, that the hypomobility in her SI joint is not coming from the SI joint or the leg itself. All right, so don't worry about the interpretation just yet. We're going to talk about that in a few slides. And again, that tutorial is in your module for tomorrow in Teachable. So the other test you can do, which some people are more familiar with, is the standing march test, which is also called Gillette's test. You're looking at single leg hip flexion. You're observing disassociative movements of the innominate bone on the sacrum, right? So you want to see, does the innominate bone posteriorly tilt as the leg goes up into hip flexion? Normal is that posterior tilt. Hypomobile would be that it doesn't tilt back. So you might see everything go together or just nothing happen, right? So this test, the big argument, some people often, especially on social media, are like, this is not reliable. Yes, you're right. A study in 1986 said that the Gillette's test is not reliable. Well, I hate to break it to you, but everybody still teaches this test in school, and it's still pretty much the gold standard test. And I have my opinion on why. And it's totally, we can talk about it more, and we probably will on the call on Wednesday because it relates to the pain provocation tests. But part of the reason is, one, people's palpation skills suck. I've taught enough people in-person classes, enough professionals, physical therapists, athletic trainers, chiropractors. There's a lot of people who don't know their bony anatomy very well. Partly that comes to people don't trust their hands because they're too in their head of thinking they need to be right or thinking about what they should feel. Secondly, also, we've already talked about how this joint is very influenced by viscera, peripheral nervous system, and the central nervous system, as well as the musculoskeletal. And so it's also like maybe some of the reliability in the research didn't take that in consideration. Probably none of it did. So I think Gillette's test is great. And in fact, in the Visceral work, they teach it so you can like assess specific different parts of the ligament to get really precise on what part of the ligament is not moving when it is. But I'll tell you what, that's about 10% of the time that it's actually structurally coming from the SI joint. The rest of the time it's being influenced by something else. And you're going to see that again with practice. Don't take my word for it. I want you to notice as you do the test and then reassess just how much it changes within a treatment session. So here's a video of that. Again, this is in your module for tomorrow. In a second, but we're going to basically from the top of the iliac crest, the top of the pelvis, and then follow that down to the point, your PSIS, on the innominate bone there. Usually it's kind of like right to the side of like the dimples on your back here. So once you're there, you're going to then go to the spine, place one thumb on the spine, one thumb below the PSIS. Then what you're going to have her do is have her march her leg up, and you're going to see what the bones do, and then back down. We're going to do 3 of them. Yeah. Okay, one more time. So for her, go back down. You see that my fingers stay sort of together, that her spine and her nominate bone are going together. Okay, now we'll check the other side. Hold on, let me get on the parts first. So I find that PSI, then I'm on the spine, and then yep, she's gonna march on the left. You can hold on the wall if your balance is not great. Good. One more time. So now what we see on the left side on her is the nominate drops down, the spine stays still. That is what we want to see. That is a normal function of the SI joint, that after they get to a certain degree of hip flexion, the nominate bone posteriorly tilts with the hip flexion. Abnormal is when the spine goes with it or it does not separate. Okay, so on the abnormal side, we're going to do the same thing with the breath hold. So get back on your points and then go ahead and take a deep breath. Hold your breath and then march your right side. Good. 2 more. Yeah. And then 1 more. And we see that normal motion come back on that right side. So this test is telling me just what the last test did, which was the right side is the hypomobile side, and it changes with the breath hold. So it directs me to do. So it's the same thing, and we'll talk about interpretation later, but you notice how it changed with the breath hold. So that's what I want you to, that's the test that you're going to be practicing. And I want you to not worry about getting it right. And even the beginning, sometimes people are like, oh, I don't know if it's mobile or not. Have them do the breath hold and test again. Sometimes when you feel it change, it becomes more clear what you were feeling, right? And so we're trying to inform your hands. So don't worry about it. I will say too, I don't want you doing this like 50 times on people. 3 times max, because it is a joint mob. And so if you do it too much, you're going to mobilize their joint and then you don't know what actually changed it. Was it the breath hold or just the joint mob, right? So that's also why you have 2 tests to use as well. We already talked about sort of why else we have 2 tests. So that's what that slide is. Does pain matter? Pain matters. Yes, of course, pain matters for your patient, but as far as interpreting the test, no, it does not. It does not influence the test. I don't care if there's pain with it. You're still trying, don't get distracted by the pain. You are still asking the question, does it move or not? And does it change with the breath hold? Now, if it's so painful that your person is clearly like in a protective mode, then it's not the right test for them. And you can try the standing march test instead. If that's still painful, not the right test for them, great news about the rest of the LTAP is it's going to give you the same information. Remember, this was a test that was a quick and dirty traffic cop. But if I do the rest of the LTAP, I'm still going to come to the same area where the body was protecting. So pain doesn't really matter though. Again, like it all depends. Again, I work with athletes who are fairly healthy. Yes, I've had people with actual true SI joint pain and SI joint issues, and I'm still able to do this test on them. So the interpretation. So this is what the flow sheet is, and you'll have this in your module, but it's probably easier to see with the traffic cop. So we have 3 options. If the SI joint is hypomobile and it changes with the breath hold, then it directs us to the viscera and the central nervous system. He's pointing over that way to the left of the screen. If there's a hypomobility and it doesn't change with the breath hold, it's a peripheral neurovascular entrapment. So on the side of the hypomobility. So we're going to treat somewhere on the leg on the side of the hypomobility. If both SI joints move, then that's the body being like, we feel great. We're not really protecting anything. That means that's the star. You get to treat wherever you want as a clinician or the patient wants, right? Area of choice, dealer's choice, I call it. All right, so those are the 3 outcomes. Don't get today, so Monday and Tuesday, don't worry about the outcome. I want you practicing the test. So what I recommend is just practicing the test and circling it on the tracking sheet that's in the module for tomorrow. And that's it. And then at the end of the day, when you're doing your notes, you can go back to that tracking sheet and then you can interpret it. So it's baby steps. First, we're just getting the repetitions in our hand to familiarize ourselves with how the test feels and how the joint feels, and if it changes with the breath hold. The question, the elephant in the room, why does the breath change things? There's really no way to know why it changes things. I have my hypothesis, which I'm going to share with you. It is the world according to Anna and what she knows from an anatomy and physiology sense, but there's no way to tell. Some people are like, well, it's a breath hold, it changes intra-abdominal pressure, so it must be a stability thing. But think about it. If it's a stability thing, then it should change a hypermobile or mobile. So I don't want to say hypermobile. It should change it from moving to not moving. Also, if it's a stability thing, then I would see a change if I'm giving stability in a different way. And I tried that. I tried like a pull down, like a lat pull down. I tried like a squeezing the ball and redoing the test, and I get the same results. So the breath hold changes without a necessarily big change in stability. You even saw that with Haley. When she put her hand on the wall and stabilized a little bit better, it didn't change the test. So it's not a stability thing. And even too, I asked the question then, when we are doing core exercises that change intra-abdominal pressure, is it all mechanical? Is it truly an increased stiffness in the core changing thing? Or is it this concept of it's changing the pressure, and pressure is the love language to the sensory receptors of the gut. And better sensory information is a clearer message to the spinal cord and the brain, and a clearer sensory message equals better movement, better output, better movement, decreased pain, more mobility, right? So that's probably what's happening, is we're just clearing up the message. And this comes up again in the other tests of the LTAP too, of I believe what changes is we're giving a clearer message to the sensory system of what's going on in the body. And so we get a different output. So what are the nerves that are providing the sensory input to the brain? The trigeminal nerve. The trigeminal nerve input is from the intracranial pressure of the meninges. The phrenic nerve is a sensory for the thorax and the upper part of the abdomen. It is a sensory nerve. It's not just telling the diaphragm to contract. The cervical plexus, also along with the trigeminal nerve, is intracranial pressure. And the vagus nerve is the thorax and the abdomen as well. And then the obturator nerve and the pelvic splanchnic nerves are the lower part of the abdomen and pelvis. So all of those are sensory nerves of our different fascial containers or organs in our structures. And when we hold our breath, even just a little bit of a breath hold, when the diaphragm drops down, it changes the pressures in all of the cavities, the cranial cavity, the neck, the thorax, the abdomen, and the pelvis. So there is a clearer message now what's going on. And mobility changes if the SI joint hypomobility was one that was strategic. So again, the goal for this week, the first few days, at least the first 2 days, if not the first 3 days, is to just simply practice the assessment. I want you noticing the change between regular breathing and the breath hold. And don't worry about interpreting it just yet. Use the tracking sheet to not get overwhelmed and just get the reps. So, call check-in. For the prizes, I'll give you this form in the chat. And I'm going to answer the questions that were in the chat and any other questions you might have. But you'll just click this form, write your name, you're going to give me any insight on what you learned today from the call, or like your big take-home message. And then the code word is banana for the day. So there's a multiple choice. You just click on banana. Like I said, this will enter you for the prizes, the live call prize, and then the end of the week prize. Live call number 2, we're going to be talking about the SI joint. We're going to talk about the treatment, why the treatments might work, and then share some cases. And I'll talk a little bit more about the LTAP Level 1 course and invite you there. So I'm going to close with this quote from A.T. Still. A.T. Still is known as the founding father of osteopathic medicine. He said, a practitioner must analyze and study their patients as if they were their best books. So this is that curiosity piece. Stop getting distracted by thinking you're the expert, thinking you should have all the answers, and start paying attention to what your patients are telling you through their tissues, not just their words. So I'm going to stop the share and then answer these questions. Kim asks, will I be emailing this as well? I'm having problems getting into Teachable. Emailing you the recording? Yes. Emailing you the daily to-do? Yes, but not the videos. So on the email from today, I provided the Teachable, like the main course Teachable link, and you can just re-enroll. It's still free. So try to re-enroll. If that doesn't work, send me an email and I'll help you out. All right, let's go back to the questions here. Someone, Ian or Ian, I'm not sure how you pronounce your name, but he said that John Barnes's philosophy advocates for this paradigm too. Yes, there's many philosophies and methods out there that look at the body like a little bit more whole body lens of view. So I love that. Kendall asked what general listening was. So general listening is an osteopathic technique that uses your hand to feel where the pattern of protection is. We're going to be using orthopedic tests to arrive at the same spot because it has a steep learning curve. And then also, I don't teach it, the Burrell Institute does. So if you're interested in learning that, definitely go to them. Alyssa said that PRI is initially taught to be very biomechanically based because you have to start where people's minds are. Absolutely. But when you actually get into it, it's all neurosensory. And she asked if I've taken the impingement and stability course yet. I have taken a couple of their courses, but yes, I know that they go deep down the neuro rabbit hole and also talk about the viscera. So yes, no shade on PRI. It's great, but I'd say the majority of people only take the foundational classes and have a hard time getting past the biomechanic part of it. So it's a great tool though, and hopefully this test will have you using their tools even better. Mary said her internet cut out when I was going over the breath hold effect on the results. Yeah, so if the breath hold changes a hypomobile joint to a mobile joint, that means that there is a visceral or central nervous system protection pattern. So that is where you would do the treatment. But again, don't worry about the treatment. We'll talk more about that on Wednesday. Effect of obesity on successive feeling the SI joint movement. So yes, different body shapes are going to make things sometimes more challenging. This is why having 2 tests is sometimes great. And once upon a time, I took a course from a physical therapist, and somebody asked this question, and he said, that's a practitioner problem, not a patient problem. So as the practitioner, then you need to use different tests that is going to give you the same information. And so if you feel like this test is not appropriate for the body in front of you, it's helpful to lean into some other tests. So with that said too, depending on the size of the person and the shape of their body and your hand, like, again, it's going to be depending on the person in front of you. I can imagine that sometimes I think we're more intimidated when it's outside of what we're normally used to versus actually trying to see what we remove. Stay with that curious point of view and be curious. Try it out. See what information you get. have them do a breath hold, see if it changes. I don't know. You'll know if it's a helpful test or not. And, you know, and this again, like why I love using the rest of the LTAP is because tests 2 through 5 give us really good information on where they're protecting to, and, you know, could get over that as a problem. So hopefully that's helpful. Linda said she works in pediatrics. Not sure if I have a patient to pet. It kind of depends on the age of the pediatrics. I've done this on children. Probably the youngest I've done it on is probably like 5. So yes, depending on the again, patient population, it might not be the appropriate test. And then same thing, the rest of the LTAP actually would probably be more helpful in that standpoint. Rebecca asked, is the timing of the breath hold important? Do instruct him to inhale and then hold the breath? Yeah, I say take an inhale and hold it. Sometimes if you, in the video I said deep breath, I would actually not say tell them to take a deep breath, because sometimes they take such a deep breath, their belly distends and then it pushes your hands out of the way and it can be harder to get a good test. So I just say take an inhale breath in and hold it. That's it. And then I do the test. So you want to make sure you're doing the test once they're holding their breath, not as they're inhaling. Preschool. So what is preschool age? Like 3? I don't know. I honestly don't know. I haven't done it on that age yet. I would think actually 3 to 5 with disabilities. So depending on what the disability is, like the March test might be doable still. You could potentially try with the seated version of the March test, you know, which is not marching, it's just seated and then flexion. Especially, you know, again, it just, you're going to have to see how it makes sense for your patient population, how you would assess SI joint mobility. And then however you would assess SI joint mobility, try it again with the breath hold, and does it change? Any contraindications for pregnant patients on test 1? Well, if they have a contraindication of lying on their back, then I would not do the supine test. I would do the March test. But other than that, that would be the only one. Is this the first thing, Caroline asked, is this the first thing I would do in a session? Yes. So on Wednesday's call, we'll talk about like a normal treatment, or like a normal like patient session, how it looks. But yes, every single person, no matter if it's SI joint pain, wrist pain, ankle pain, knee pain, ankle sprain, whatever it is, I'm always starting with this test, because this is the traffic cop telling me where I need to go first. So I start with this test. And then before I do treatment, then I test all my other orthopedic things. Because again, I'm trying to get that orthopedic list to go from like 25 things to 2 things. So I need to at least know what the orthopedics were at the beginning, what the body is presenting to me as, before I do the intervention. So I do this locator test, the SI joint mobility test. I let the traffic cop direct me. Then I pause before I do treatment, and I'm like, okay, you're here for an ankle sprain. Let's check out your ankle. Let's check out your hip. Let's, whatever you would normally check for an ankle sprain. And then I do treatment. If it directed me to the visceral central nervous system, I might start with some sort of like, let's say I start with trigeminal nerve glide. And then after I do the trigeminal nerve guide, I reassess the orthopedic stuff and see how it's changed. And that's when your brain is going to explode, because you're going to be like, how did a trigeminal nerve glide change their ankle dorsiflexion? Right? So yes, still do your normal assessment on people. But this is for everyone, not just SI joint pain. But we'll see on Wednesday's call, it's going to be very helpful for your SI joint pain patients too. You're welcome, AZ. Thanks for being here. Linda said her children may not verbally understand, but I'll try. I mean, you know, however you would normally do an assessment on them, like if you're showing them visually or that kind of thing, give it your best try and let me know. Send me a message if you need more help. The more I can understand your practice and how you normally would assess someone, the better I can help you out with that. Mary also asked, when using this test, what percentage of your patients reveal upper extremity versus lower extremity disorders? Mary, I'm not 100% sure of your question. When using this test, again, it's just directing me where to go. So somebody will come in with a shoulder pain and I'll still start with this test because it's telling me, is the shoulder pain a driver from it being visceral or central nervous system, or is it coming from one of the lower extremities? Would I skip the SI test if the client had the surgically fused SI? Yes, because it's not a great test anymore, because it's not going to change if it's fused. Yep. So that's, again, when the rest of the LTAP is going to be more helpful in a patient like that. Absolutely. So we are only going to use this test if it is a good test to use. And it's a good test to use when you know that there is a capability of the test of the SI moving. Caroline said, when you said you could use this for a virtual test, are you having the patient draw a mark on their skin and watching, or just watching? I just watch because I've done the March test enough and I've watched it now enough that I can kind of just visually see it. If you're new to this, you're going to have to be doing it in person and paying attention in person until you feel more confident in the virtual setting, but also try it out. You're never going to get better at it if you don't try it. So try it, do the breath hold, because most of the time virtually, sometimes I have a harder time at first. Like I'll have them do the March test and I'll have an idea of like which side I think is hypomobile or not. And then I'll have them hold their breath. And when it changes, it's much more clear. So when it changes, then I know where to go. If they hold their breath and it still looks the same, then I know it didn't change. So now I have a 50% chance of getting it right of what side to start treatment on. Or if I feel like they both moved, then I can go wherever I want. So yeah, that's how I kind of do it virtually. Ian said, if an athlete has impingement or lack of range of motion in a hip joint due to protection pattern, but seems improvement with breath hold, how long does it typically take to reprogram the body when it's nerve related compared to muscular related? Well, if it's the hip joint, so if it's the hip joint, you're asking, so if they have like hip impingement and the SI joint test tells us they're protecting, it improves with breath hold, so they're protecting nervous system or visceral. So that's where I'm starting treatment. And then we retest their hip. How long does it take to reprogram the body? Well, sometimes it's pretty quick, and sometimes it sticks. So for example, and this gets into a little bit of like understanding like hip impingement. A lot of times people are having hip impingement and labral issues when their pelvis is in a position that their joints really exposed, or they're in like a posterior tilt. Posterior tilt is often commonly a protection pattern. So if I get them out of her protection pattern and their pelvis goes into a normal version, which is anterior tilt, about 12 to 15 degrees of anterior tilt, now they've taken that anterior hip joint and they've sort of the femur sort of sat back in the socket. Now they might not have hip impingement symptoms at all, because their joint is in a completely different spot. So in this scenario, it may be very quick, and you'll be surprised at sometimes these long-standing protection patterns. When you finally do treatment in the right spot, you don't need treatment all the time, and like it holds for weeks at a time. So I would say I don't have a standard response for the answer, but you're going to be surprised sometimes. Now, the key with this is this test just gets us to that it's a visceral or essential nervous system problem. The more specific I can get, right? So if I can use the rest of the test to be like, oh, it's their liver, or oh, it's their trachea up in their neck, or oh, it's part of their cranium. When I can get more specific like this, then I'm going to have an even longer lasting treatment response and change in the dynamic alignment that is going to change that hip impingement pattern, right? So hopefully that makes sense. Yes, you are welcome. Those of you who have to go, I know it's 8:10. Oh, so 8:10. So we're 10 minutes past 90 minutes. So if you have to go, no problem. I'll stay on a little longer and answer more questions. But thank you for being here. I'll be sending out a recording. It'll take me a little bit to process it because I'll also put chapters on it for everyone. So working with scoliosis, is there a difference? Yes. So the important thing with scoliosis, and this is in the module and Teachable, is when you're doing both the supine test or the march test, you want to meet the body where it's at in the person's curves. So you need to use towel rolls or bolsters or wedges to make sure that they're in their curves and then do the SI joint test. If you just lay them on a flat table and they have a curvy body, then they're already taking slack up in the plane of movement. And so you're going to get a false test. It becomes not a good test anymore. You're going to come up with hypomobility doesn't change with the breath hold time after time after time. So you want to meet them where they're at. That makes the body already feel better because you're meeting them where they're at. You're not forcing them, right? So we make them comfortable. We meet them in their curve, and then you test it. You're going to get way better information out of that test. Any test for this matter. If this is the one thing you get out of this free education, when you're doing any sort of supine or prone or even standing assessment on people with scoliosis, I would first look at things where they want to be. That doesn't mean you're going to keep them there forever, right? You're going to still do your magic at changing their curves over time with exercise. But the more you can meet them there, right? This is why you use the wedges during the exercises, because when you meet the person where they're at, their body is going to integrate and move and lengthen the curve better on its own, right? So you want to test in those positions too. It's Laura, it's totally up to you of whether you think the march test or the supine test is better. I would play with both, but you'll see in the video module for tomorrow, you'll see me with a scoliosis, though not severe scoliosis patient, in the placement I use for towel rolls for her in the supine test. Yeah, you're welcome. Cool. If there's any other questions, holler. Yeah, you're welcome. Thank you for being here. It was fun. I hope you enjoyed it, and I hope to see you all on Wednesday. All right. Have a good rest of the Sunday.